Okay. So, good evening, poor urology viewers. Today, we are seeing almost a semi-live case of supine PCNL. As it is a surgical technique related, we have a youngster who is regularly doing supine PCNL, who is very keen interested in endourology, Yash Pamecha. I will share his screen to introduce, and then I will hand over the program to him. So supine PCNL semi-live, as you all know, there is role of supine PCNL definitively now. Lot of people are already establishing, and they learned and they are taking advantage of supine PCNL mainly because of ECRS. Dr. Yash Pamecha is a urologist MCH working as private practitioner in own setup in Mandsaur, MP, Madhya Pradesh of India. Worked in Department of Urology in SAIT, GSMC and KM Mumbai for 2 years on the post of assistant professor and specialty medical officer. Presented a paper on role of supine PCNL in difficult upper ureteric stones in UAE at Dubai. Co-editor of the book of genitourinary tuberculosis published by JP Publishers in year 2020. Contributing author in the same book on genitourinary tuberculosis. Invited as faculty to deliver the symposium Role of Psilocybin in Male LUTS as West Zone UCCON 2019 at Rajkot. Awarded Best Paper Presentation on Assessment of Etiology, Management Options and Outcomes in Complex VVF Patients at Mumbai Urological Society Annual Meet, Lonavala 2016. Published papers, Laparoscopic Assisted Percutaneous Nephrolithotomy in Chronic Kidney Disease, Patients with Ectopic Kidney, Use of Ilium for Complex Ureteric Reconstruction, Assessment of Long-Term Outcome, Complications and Impact on Renal Function. With this introduction, I know him personally, close friend of me, and definitely he is going to give important hints, important things about the supine PCNL. Over to you, Yash.
Thank you, sir. First of all, thank you for such an elaborate introduction to the group. And at the outset, I would also like to thank you for giving me this opportunity to present my work on supine PCNL. I am very thankful to you and the Pure Urology Forum, which is a very eminent forum on Facebook. Thank you, sir. Thank you so much.
Okay, start.
So I'm starting. It's a pre-recorded semi-live session.
Okay.
I'm starting the video. CT scan. First, these are the cross-sectional cuts. You can see there is a stone in the pelvis of the right kidney. It's a big stone around 20-25 mm. Then there is another stone which is in the pelvis and one in the lower calyx.
Okay.
So these are the cross-sectional cuts. Now looking at the 3D reconstructed images. You can see a big stone in the pelvis on the right side, one small stone in the mid pole and one stone in the lower pole and one more in the lower pole, both in different calyx. One is in the medial calyx and one is in the lateral calyx of the lower pole. So total 4 stones are seen on the 3D reconstructed images. And now looking at the contrast images. So as to plan the puncture, I think we should get away with this stone by taking a puncture on the lower pole in the more lateral calyx, and I think we will be able to go into the more medial but anterior calyx, because one stone appears to be in the anterior calyx of the lower pole. So these are the CT findings. Now coming at the OT table setup, this is our OT trolley. So basically we have one betadine bowl for painting and dripping, one kidney tray with normal saline, one 10 ml syringe, and amongst the instruments we usually do a single step dilatation. So we have a single step sheath. We have all the sheaths ETO'd, so we can open of the size whatever we require on the same moment. This is a 22 French sheath. This is a 18.5 French UMD nephroscope. We have IP needles, screw dilator and a guide rod. We have a ureteric catheter, with guide wires. We are going to use pneumatic lithoclast. So this is the sterilized pneumatic lithoclast handle with the tubings, and basically we have all tubings and camera cover and etc. So not much clutter on the OT table. Now coming to the patient position, and this is the patient position. As you can see, we are going to operate on the right hand side of the patient. Patient is under spinal anesthesia, and we have put two bolsters, one below the buttock and one below the scapula of the ipsilateral side. Patient is positioned such that देख पीछे ट्रॉली है, थोड़ा सा पीछे ले ले ट्रॉली को. The patient is positioned such that the ipsilateral leg is lying almost in the supine position. It's hanging down very straight, so that we get the maneuverability to access the lower pole, because when we are going through the lower pole, the direction of my axis will be like this. So my leg should be as straight as possible in line with the hip and with the back. And the opposite leg is in the modified lithotomy position. So this is the position which is flank free. You can see the flank is completely free from the surface, flank free, slightly oblique, so oblique supine, and modified lithotomy because of this thing. One leg is almost straight, low lithotomy, just like a French lithotomy, and one is in the normal lithotomy. So this is the position. Now coming to the hand of the patient. Now since the patient is not under general anesthesia, he is under spinal anesthesia, we can ask the patient to keep his hand above his to keep his shoulder above his head like this. If he is feeling slight discomfort after dripping, we can ask him to keep his hand like this, rest it on the chest. So these are the two comfortable positions for the patient, and usually patient doesn't complain of any pain. Very rarely it happens in some cases that patient complains of pain in the shoulder, but we can easily change the position of that hand as and when required. So C-arm is coming from the opposite side. We have the C-arm monitor on the foot end of the patient, and we have the camera system on the head end of the patient. So this is the usual setup that we do in every case of supine PCNL. Now coming to the marking. So usually we do marking in the standing position, but here since the marking has not been done, what you have to take precaution is ask the patient to keep his hand resting by the side and then see the posterior axillary fold. This is the posterior axillary fold. The patient's hand is resting by his side. This is the posterior axillary fold, and now from the posterior axillary fold we are drawing a straight line up to the iliac crest. This is the straight line that you have to draw when the patient's hand is resting by his side. This is very important, because if you draw this position in this, if you draw the line in this position, if you are drawing the line in this position, this line will go above, which we don't want. Why? Because the more the line goes anteriorly, there is more chance of injury to the colon. So it is very important that the patient's hand should be lying by his side, just like the way you stand and keep the hands by your side, by the side of your shoulders. So this is very important, and then you have to draw this line. After that you can ask the patient to keep his hands above. So this is the posterior axillary line that we have drawn. This is not the correct line, this is the correct line. Now we have to see where is the 12th rib. So usually the tip of the 12th rib coincides with this line or just lies posterior to it. So here is the tip of the 12th rib. So we are drawing the 12th rib, and then we are drawing the 11th rib. So this has to delineate the intercostal space if at all we require upper calyx puncture. And this is the iliac crest. This is the iliac bone, and this is the iliac crest. So this is how the marking has been done. Now we will paint and drape in the same position. Nothing is going to change while doing RGP, while placing a retrograde axis, and while making an antegrade axis. So this position is now all settled. The spine is quite posterior here, and the flank is completely free. Okay. Now moving to painting and draping. So this is the final position after painting and draping. We have already placed a ureteric catheter 5 French in the right side pelvic ileal system, and now we have painted and draped it properly. You can see the markings. This is the 12th rib, this is the 11th rib, this is the posterior axillary line that we have drawn. Now we have connected a 10 ml syringe which is having the contrast mixed with normal saline through this ureteric catheter, and this has been connected via 3-way. One of the channel is being used for saline irrigation, and we have connected this saline irrigation to the 3 liter normal saline. So this will be helpful for the retrograde saline irrigation, and this is the contrast. Now we are going to do an RGP. Start the RGP. Continue shooting. So this appears to be a very obstructing pelvic stone. Slowly inject the contrast so as to prevent any extravasation or intravasation into the system. You can see good dilated upper calyx.
Now you tell me.
Lower calyx is also well dilated.
You tell me.
Very important that you make a RGP by yourself,
Which is anterior calyx.
because you know how the
pause the
system is
video?
appearing, how you are
Yes,
going
sir,
to
I'm
plan the
pausing the
puncture.
video.
So today we are planning to operate a case of bilateral renal stones, and very rarely it has side. Just will paint that we have drawn.
Now I have paused.
Yeah.
Hello?
Yes, sir, I have paused.
Yeah, I have paused. Anyway, when you inject the contrast like this, okay?
Slowly inject the contrast
How will you know that
so as to prevent
is
any
the
extravasation or
anterior calyx
intravasation
and
into the
which is
system?
posterior calyx? Are you able to listen me? Hello? Hello?
Yes, sir.
You are not able to listen me?
Can you repeat the question, sir, please? One more time.
How do you know there are different calyces? Some are dark, some are light. Do
Yes,
you
sir.
have any idea which is anterior calyx, which is posterior calyx in this?
Sir, in this RGP, if you have noticed, in the lower pole, the calyx which was filling faster is the posterior calyx. That is the lateral lower calyx. And the calyx that was filling slower and delineated quite late after adequate amount of contrast pushing, that was the anterior calyx.
Okay,
Because
proceed.
we are doing PCNL.
Okay, I will start again.
Yeah.
You can see good dilated upper calyx. Lower calyx is also well dilated. Very important that you make a RGP by yourself, because you know how the system is appearing, how you are going to plan the puncture and everything. So RGP you should do it by yourself. So the one dark blotch which is appearing in the lateral lower calyx is the posterior lower calyx, and the one which is appearing medially appears to be an anterior lower calyx. This is because the more amount of contrast has gone into the lateral lower calyx. That's why I think it is posterior. But anyways, in supine PCNL, anterior and posterior doesn't matter. You have to take the puncture from the most lateral part of the calyx, and that too by its tip or by the end. So now we are planning a puncture. I think I am going to go by this calyx, and I will go anteriorly for retrieval of that anterior calycial lower pole stone. I don't think I might be able to go into the medial calyx. So I think I'll have to take one more puncture. Shoot, continuous. Stop. So this is how I have drawn my angle of entry by placing the needle on the intended side of the puncture. And now surface view please. So the tip of my needle is here and the calyx it is showing on the C-arm here, but you have to go below the posterior axillary line. So actually it is posterior. This on the surface it is appearing anterior, but actually your direction will be like this. So anywhere below the posterior axillary line I am taking the puncture. Surface view please, come keep on playing surface view. So here it is going to be like this and my angle of entry will be like this. Shoot, continuous. So I can feel the movement of the kidney. C-arm view.
Are you sitting or standing?
I am
I
standing, sir.
have to confirm it on the 30 degree. So I am placing my C-arm, I am shifting the direction of my C-arm from 0 degree to the 30 degree cranial end of the patient. Whether I have gone into the calyx or I am anterior or posterior to the calyx. So here the needle appears in the calyx. Okay.
Yeah.
Now nothing is coming. 2 cc please. 0. So blood is coming. That means I am in the parenchyma, but I have not reached the pelvic ileal system. Shoot. So again, C-arm view please. Now again I have shifted my direction a slightly. Shoot. 2 cc. No, it's blood. So again,
So even in the both the three directions, if it
Yes.
is present, still blood comes sometimes. Why?
Yes, sir. The blood
0.
will still come if your needle is still
So now it is
mucosa.
clearing out. Yes. So that is the stone and I hit. Now you can see clear water coming in.
So what is the adjustment you have done?
Just a few,
So sometimes when
hardly
the
a
needle goes
millimeter of
too deep,
adjustment you have
the
to.
water doesn't come. If it
For
hits the
in 30
mucosa, the
degree,
water
we have
doesn't come.
already seen that
Now shoot. C-arm
the
view please.
direction was proper.
You can
Once
see on
we
the
are into the
C-arm, the
calyx,
wire is going
it is
straight into the
possible that we
ureter.
might have gone a bit deep into the mucosa.
Okay.
So this happens.
So that might be another reason for the.
Hello?
Yes, sir. So this
If
might
you are
be
in the
another reason
parenchyma,
of blood
there will be
in the
frank blood.
puncture. So just withdraw a needle
If you are
1 or 2
gone too
millimeters,
much
and the
deep
water
into
will
the
start
calyx and
coming.
if the tip of the needle is hitting the mucosa of the calyx, then also the water doesn't come. Just take a 2 ml syringe and withdraw the needle. Now I will take one more puncture in the middle calyx. Probably I will use that for harponium. Shoot. Yeah. Shoot. Because one small stone is in this middle calyx. Stop. Now again the surface view. This is how I have marked the location of my needle. And now I am going below the posterior axillary line. Now one thing here is, since I have gone from lower calyx from this angle, I presume that the middle calyx is more posterior to the lower pole. The mid pole is more posterior to the lower pole. So I will go a little bit down from my previous puncture. Here. Again it is a subcostal puncture only. But the direction will be again a bit posterior. Shoot.
You wanted to puncture before only other calyx?
Yes, sir. Usually I take a puncture and park the wire in the first
So you
row
can
only.
see the movement of the
If
kidney,
at all it
movement
is
of the
needed, then I
kidney,
dilate it. Otherwise, I don't
what
dilate.
purchase I am getting,
But
and I
punctures I
feel
usually
the giveaway.
plan the punctures
Again, 30
beforehand
degree,
only.
please. So this is to confirm the anterior and posterior. Shoot. Now the needle has gone above. That means I am not in the calyx. I have to shift my puncture more anteriorly. So this modification I will do in the 30 degree only. So see the direction of my needle now. I am going more anterior. Stop. And I am getting the water again.
Very good.
Focus on this. Yeah. So this is the thing you have to follow. Always confirm your puncture which you have taken in 0 degree by seeing in the 30 degree. Again see. The wire is going neatly into the ureter. See on view please. Shoot. So the wire has gone into the ureter. And this is through the midpole. Now this puncture I am just keeping for the sake of keeping. I will withdraw the needle and I will secure my guide wire. How's that? So 0 and 30 cranial is very important in supine PCNL because you know the depth whether you have to go anterior or posterior to reach to that calyx. This is done by seeing the needle in 30 degree. Puncture you take in 0 degree. So after tilting the C-arm to cranial 30 degree, if your needle is moving along with the C-arm, that means it is shifting cranially to the intended calyx. That means you are more posterior, you have to go more anterior. If moving the C-arm 30 degree cranially, your needle is lagging behind the calyx, it is going caudally, the needle. That means you are more anterior, you have to go posterior. This is the concept that you have to remember. You can see the colonic, focus on the C-arm, don't focus here now. You can see the colonic shadow and it is not moving with your movements of the screw dilator and wires. That means you are very posterior to the colon. So this is there in supine PCNL, you get a very good colonic shadow. So you can figure out whether you are going in the colon or not. Now the needle has gone inside, the screw dilator has gone inside. We usually do a single step dilatation. Stop. We are placing a guide rod. And then stop. So you can see at every step you have to confirm whether the water is coming or not. So you can see through the guide rod the water is coming. That means you are very much inside. And you are making the use of this saline irrigation through this 3-way which is connected to the 3-liter normal saline so as to fill the pelvic ileal system continuously with NS. Shoot please. This has gone inside. Again the water is coming through this emplas sheath also. This is a 24 French emplas sheath. Shoot continuous. My assistant is holding the sheath. So this is because to prevent over dilatation. Because suddenly with some jerk there is a possibility that sheath might the emplas dilator may hit the pelvis. So one assistant is holding the emplas sheath.
Correct.
Now I have filled the giveaway. I am withdrawing my dilator and guide rod. See the one of the stone, that secondary stone is already coming. It has come out. Let the vision get cleared a moment. Give the So this is how it is, and this is the lower pole stone, the bigger one. I don't think it will come through this 24 French sheath. So probably, please increase the light, yeah. I think I'll break it into two and then retrieve it out. So you can see it's a perfect puncture, and you can see, bas, that's it. Show the surface view. Surface view. You can see clear water coming out through the pelvic elicial system. This is the clear irrigant fluid.
Are you flushing anything from below?
And you can look at the direction of the angle of my sheath. It is perfectly horizontal. So this should be the direction of the entry in supine PCNL, so as to get a good effluent saline. So I am going to break it into two pieces. So I have started breaking the stones now, and you are getting a clear water to your effluent, so that means the puncture is good. It's a very hard stone. I'll make few holes in the stone in the center, and then we'll go to the periphery. So this is the usual method that I choose to break the stone. So most of the fragments will pass on their own. You can see that where these fragments are passing on their own. So you can see the angle of my sheath. It is closely abutting the buttock. That's why this leg should be as straight as possible. Many a times it happens that the assistant has to press the buttock inside so as to get a good angle. So getting that good angle is very important. But it's not that difficult or not that uncomfortable for you.
We do the complete surgery in standing position only, sir.
Yeah. I'm watching it. And if you wanted to do RIRS in this position, can you do it?
Yes, sir. I am very comfortable in doing RIRS in this position.
One leg straight RIRS, no problem?
No, sir. I have not faced so far yet.
Yeah. Are you doing ECRS?
Yes, sir. Partly I am doing because I am the only surgeon. So I have to change the
Now
position.
this is the anterior lower calyx, which was medial, that I was talking about. I have gone into that, and I am making the stone fall into the pelvis.
Sometimes if we have to negotiate
Bit
from
difficult
posterior to
because
the
it is a
anterior
smooth
calyx,
stone.
when the angle
Hopefully
doesn't
I should
permit us
get
to
it.
do it in the standing position, that time I have to sit down on a stool.
Yeah.
Yes. So
If
this I have brought into my vision.
anterior
I'm
calyx
advancing my
from the
sheath so as to
sometimes.
block that entry of the anterior lower pole, so that the stone shouldn't migrate again. I already made 2-3 fragments. I'll just retrieve it. And so our lower pole stones and this thing, pelvic stones, is cleared. What is remaining is
One
one
challenge
small
in supine
secondary in the
PCNL
middle
in
pole.
dilated system is, sir, the
So our
amount of
puncture was
irrigation
in the
required is more and
lateral
still
lower
the
calyx, which was
kidney
more
remains collapsed.
posterior.
Yeah, repeat.
The one challenge in supine PCNL that we have noticed is in dilated kidneys and obstructing stone, the system is so much dilated. And the amount of irrigation required is more and the kidney remains collapsed.
Yeah.
So sometimes we have to raise the height, sometimes we have to give manual pressure to the irrigation
Correct.
bottle as
Correct. You have to use.
As compared to the secondary stone bearing medial lower pole calyx, which was more anterior comparatively. So it doesn't matter where you take a puncture, whether it's in anterior or posterior, you have to take the puncture through the most lateral calyx, because the direction of sheath is very horizontal. You can go anterior as well. Recording is on. So this is the calyx through which we have taken the puncture. Give me 4, sir. This is the lateral lower pole calyx, which is more posterior. You can see the papilla behind the stone.
Do you recommend this calyx which you are saying posterior? Is
Yes.
it easy? Is it easy in supine or is it difficult? This calyx normally, this calyx is the one which is targeted in prone.
In prone, yes, sir.
But we will try to be little anterior in supine.
Exactly, sir. Usually the calyx you puncture in supine is usually anterior calyx only. For
Yeah,
prone, your direction should be more downwards.
anterior or lateral?
Anterior, sir.
Anterior.
Yeah.
Okay.
But here in this case, this lateral calyx, the lower pole lateral calyx was posterior one.
Yeah.
And the anterior one was more medial.
Yes.
And I will show you how I went into that anterior lower pole calyx, which was medial. So this is the papilla, okay?
Yeah.
This is the papilla. And this is the medial lower calyx, which is more anterior. Now look at the direction of my sheath. Surface view, please. So I have gone into the more medial and anterior lower pole calyx, which was bearing one secondary stone. You can see on the screen on the monitor that I have seen the papilla of this calyx as well.
Yeah.
So this is completely clear. Gently I am coming down.
I must emphasize here that this type of movement from the posterior to anterior is possible more in supine. It is not
Yes.
easy to go from posterior to anterior in prone.
Yes, sir.
It is slightly parallel movements. So you can go to the upper calyx easily. You can go to the intracalyces of the lower calyx easily. The only problem is middle to lower, lower to middle is slightly tricky.
Because we are taking the puncture from the lateral calyx and mid pole is also very lateral, so they become very parallel to each other.
And parallel to each other, that is the only disadvantage. Correct.
Yes.
This is the pelvis. This is the pelvis, which was bearing one more stone. So this has been clear. There is no bleeding. You can see the effluent. It is very clear. Now what is remaining is a small secondary in the mid pole, which I can't go through this lower pole. So you can easily go into the upper pole. You can see on the monitor that from this lower pole I went into the pelvis. Now through the pelvis I am going into the, I'm trying to go into the upper pole. I think I can go in. It's a big scope. It's a 19 French scope. Had I been using a mini puck, I would have easily went inside. See, this is the upper pole. You can see I have easily went into the upper pole. Infundibulum is a bit narrow. For this scope to enter inside, there is no fragment that has migrated into the upper pole. So I am not trying to dilate this infundibulum. And again I am coming back. There is no bleeding. This is the pelvis again. And this is the papilla of the posterior lower pole calyx, which is lateral. Okay. I think this part has been clear. We'll now see what we can do for that mid pole secondary stone, whether we can inject saline, push the saline and bring it down into the pelvis. Let's see. So you can see one secondary in the mid pole.
Yes.
Stop. Shoot. Siam view, please. Shoot. So the stone is moving, but it has not yet come out. The stone is moving with saline. Shoot, shoot. It's not coming out. So better not to waste time. We'll take a small puncture over that. Shoot.
Actually, the infant was not very
large.
yes. Otherwise, it would
We
have
will
come
do
out
a
with
single
saline
step
push.
dilatation for this. Shoot.
Can you do mini per 12 French?
Yes, sir. I use mini per 12 French with a 16 French sheet.
Okay.
Push water. And I'm holding it and I'm bringing it out.
Very
So this is the end of. So this is that mid-pole puncture, and you can see the infundibulum, which is very narrow. Probably that's why the stone was not coming out. And this is the papilla of the calyx, mid-pole calyx. So we are very end on. Chalo. So as to see whether I have left any residual.
This I'm using a
You can see
flexible
the
system
wire here.
laparoscope, sir.
This is the wire. This is going into the pelvis. Now I am going into the lower. This is the upper pole. This is the pelvis. Ureter, ureteric catheter. Now I have come out. And now I am going into the upper pole. This is the upper pole.
Yeah.
You can see a dilated upper pole. Okay, shoot please. Give me a shoot. Here only. This is the upper pole. Stop.
Very nice.
Okay. I think something has washed out. There is, but I think there is one fragment in the. This is the upper pole. Now gently I am coming out through the upper pole. Now I will try to see the middle pole, which is the difficult part. Shoot please.
And with flexible system laparoscope, it is difficult to go from lower pole to the mid pole, sir.
Even whatever from in supine PCNL, lower to mid is very difficult.
Very difficult. You have to hit the pelvis and then you have to use the passive deflection to make the entry
This
into
is
the
the
Depends on
upper.
various factors, angulation, infundibular length, narrowing of the infundibulum, many factors. It is really better to
So going into the middle
or you
pole is
do
very difficult
RIRS.
through lower
That is
pole,
very
even
easy.
with this
do IR.
flexible scope.
Here ECIRS has definite advantage.
Definitely, this stone I might have looked at
This is pelvis.
the one which you dilated, nicely punctured, but I might have looked at RIRS very easily, made two pieces and then bring it to the lower pole puncture.
Lower pole in front of the sheath.
This is the upper.
Yes.
This is the mid. This is the contrast in the mid pole.
Excellent.
Shoot here. Take it there. Take it there. So this is the mid pole. There is no opacity. All the contrast has been drained. Stop shooting.
Even if you withdraw the ampla sheet, sometimes
Take the
it's
Siam.
easy.
This is the mid pole.
Sorry.
So we have confirmed all
Yes,
the
sir.
calyx. There is no residual fragments anywhere. Stop. So this we do at the end of every PCNL so as to confirm complete clearance on table. This is a BioRed flexible scope 13.5 French. Now come on the Siam please. So this is the final image. We'll just give a 10 minutes compression. We have not put any nephrostomy in any of the punctures, the 2 punctures that we have taken. That's it. Thank you.
Good, well done. So I will ask quick questions.
Yes, sir.
If you are not getting water repeatedly, what are the steps you take? You think that every time giving away is there, every time needle is there in the calyx. What are the steps you take to be in the calyx properly?
Sir, if the water doesn't come, even if you think that you have made a good puncture, you are in the calyx, you have confirmed in 2 positions on the C-arm, try flushing water from below through the ureteric catheter. Sometimes the water may come.
Okay,
If
yes,
still not coming, then just take a 2 ml syringe and aspirate negative suction and just withdraw slowly, millimeter, half millimeter, half millimeter. Sometimes the tip of the needle may be upperting the mucosa, or it may be not in the alignment with the infundibulum of that calyx, so there is a possibility that water may not come. Sometimes in anterior calyxal puncture also the water may not come. So by negative suction you may get water.
correct.
Even if you don't get a water and if you still think that you are in the system, just pass a guide wire. Don't push it too harsh because even guide wire can perforate the system. So just try to pass a guide wire and it will give you an idea whether you are in the calyx, the wire is coiling in the calyx. Sometimes the wire may directly go into the pelvis also. So this is the third thing that I do. Even if the guide wire doesn't go, then I withdraw the needle completely, make a new puncture.
Correct. So I try to pass the guide wire in the first go, then
Okay.
only I will aspirate and come out. First I will give
Okay.
chance for guide wire in your order. Otherwise, there is no problem. Personal choice, no problem. Second
Okay, sir.
question, when you are dilating,
Mhm.
you dilate initially 6 French, 8 French, 12 French sequential dilatation so that you will have some free hand in the subsequent dilators.
Okay.
Do you dilate or don't dilate?
No, sir. Usually now I don't dilate. Initially, during my training days, we used to do it through serial alkane dilators. But currently, I am doing single step dilator, sir.
In single
And plus,
dilator, if you are using too much force, if the alkane rod or anything goes more medially impacted stone, it is disaster. How will
yes,
you
there
prevent
is a
that? It is very tight sometimes in a post-operative cases or well-built male persons.
yes, in muscular patient, it is very difficult. Here, the role of your second hand is very important, sir. In
Yeah.
supine PCNL, because there is a free go. So you have to control the movement of the dilator with your second left hand. So the right hand is doing a screwing movement and the left hand, index and thumb finger is regularly controlling your movements inside. So at every point of time, you have to check the movement. Because if you suddenly push from your right hand, that may cause injury by overdilatation. So my left hand is very important here because I just don't allow it to go inside. And my assistant is holding the central guide rod by his hands. I don't have a control over the central guide rod. The central guide rod is holded by my assistant. What I have in my right hand is the Emplas dilator and in my left hand is the Emplas sheath. So that's how I try to control my movements. And very slow dilatation you have to make, sir.
Yeah. And in case if the bleeding occurs, if you raise the pressure from the ureteric catheter, if the bleeding decreases for some time, do you use any pump or anything from below and above so that you can take out the water more faster?
No, sir. I don't use any pumps.
Hmm.
Just irrigation. That 500 ml NS is only for the passive irrigation or the gravity irrigation. If I think that there is some bleeding, some oozing, or the system is collapsing more than what I want, I ask my assistant to use a 10 ml syringe and do manual irrigation. That's it, sir.
Do you use laser during any of your PCNLs?
Sir, in mini perk, I do use lasers.
What laser and what setting?
Sir, usually I have only thulium fiber laser in my setup. So the settings I curtail or I manipulate on the basis of the hardness of the stone. I don't do dusting. I just do fragments and suck them out using a super perk sheath, which is a 16 French sheath. So
So
the settings
you
usually
feel supine
around.
PCNL super perk sheath helps a lot?
Yes, sir, definitely it helps. Because most of the time it is a closed system, so the system is very good distended and there is no wastage of water. And when I want to suck the fragments, I start suction. So Super Perk, I found better advantage than routine M plus sheets of Super Perk sheet in supine PCNL especially.
Have
It
you done
helps the system.
have you done staghorn in supine PCNL?
Yes, sir, I have done stagons in supine
Did you
PCNL.
face any problems or it's okay?
No, sir, it's okay.
What size maximum you dilated so far in supine PCNL?
Sir, I have dilated up to 30 frames, sir.
In staghorn, that is better?
Yes, it is definitely better, sir, depending upon the system as well and the stone load. You should have a good system so as to accommodate a 30 French sheath. Bulky stone load, it definitely helps to clear big fragments, that too without the use of forceps. So it saves considerable amount of nephroscopy time.
When you do RIRS after supine PCNL, I feel very difficult because of the blood clots and everything. So you wanted to do RIRS first or supine first if small stones are there?
So if small stones are there, then definitely I will do RIRS first and try to relocate them to a favorable position towards my intended point of puncture.
That is very important. That is correct.
Yes.
Because after doing PCNL, getting back into RIRS is difficult.
It's difficult, sir. And system also doesn't expand very well, sir, because you have a sheath placed inside.
Do you believe in bilateral surgeries? Same time?
No, sir. No, sir. I refrain from doing bilateral surgery still.
I
I
also
just
feel
try
because
to be safe.
I also feel the same, because any risk to one kidney
Yes.
or two kidneys, the patient may suffer, whether it is RIRS, whether it is PCNL.
URS also.
Even
Even, sir, if a very small ureteric stone on the other side, we can attempt, but no simultaneous renal surgeries. No.
correct. So with this, we will conclude the session. Nice discussion. And you have
Thank you, sir.
explained, even though punctures were initially not getting, is almost a live surgery. Future
Yeah.
in the world, the training and teaching will be on simulators as well as semi-live surgeries, because the stress
Yes.
will not be there on the surgeon. And you can also explain better what you have done retrospectively, so that you can give a proper message. Otherwise, surgery is same. You did a good job, and it will be very helpful. More than 100 people have seen the program so far. So let's hope in future we will do some more with you. Thank you very much.
Thank you, sir.